Pancreatic cancer is one of the deadliest cancers you can get, killing 85% of the people who get it. Not for nothing, oncologists and biomedical engineers have been trying for decades to try and find a cure. But for over 40 years, the protein that drives the vast majority of cases was considered to be undruggable. That's right, despite knowing the single amino acid that was incorrect on this single mutated protein, scientists couldn't do a single thing to correct it. This undruggable protein, it's called KRAS. Big emphasis on the ass. But last week at the biggest oncology conference on the planet, a phase 3 clinical trial readout showed that a new drug could cut the risk of death by 60%. All that in a pill. Yes, just a single pill every morning with your breakfast, your morning coffee, and your morning K-Rap. Not the usual chemo by IV that keeps you in the hospital all day. Today we're going to break down the science of how they did it. Look at the clinical trial data, the mechanism, and the chemistry that took almost 4 decades to figure out. What's up, nerds? Before we go into the clinical trial readout, let's get a few things straight. All cancers suck, all cancers are different, and pancreatic cancer is extra different. Like, really, really bad different. It's estimated that it has a 5-year overall survival rate of 13%. 13% chance that you make it 5 years after diagnosis. It's widely considered one of the deadliest cancers you can get. One of the main reasons is because most patients don't develop symptoms that they can catch until after the cancer is spread, till after it's become metastatic. It's very hard to treat cancers that are already that aggressive, but there are still options. Doctors will usually prescribe a very robust chemotherapy and deliver it intravenously, so deliver it all throughout the body to try and catch any cancer cells that are floating around. And this works for some patients, but after a while, that treatment stops working. The cancer's too aggressive. So patients need a second line of treatment, which for a long time really just meant trying a different chemotherapy that hopefully kills the cancer a little better. Before this newest trial, this newest drug, the median overall survival for a pancreatic cancer patient starting this second line treatment was just 6.7 months. No. It's whack that this is the best we can get since we've known what the mutated protein that causes 90% of these pancreatic cancers. It's a mutated form of the protein KRAS. And to fully understand why he's such a stinky bastard, we really have to get down and dirty with some good old biochemistry. KRAS is one of your cell's growth accelerators. Normally, KRAS is turned on just briefly enough to do its job, to tell cells to grow and eventually divide. Then when it's done, it turns itself off. That on-off cycle is determined by which molecule is bound to it. When it holds GDP, guanosine diphosphate, it's in the off state. When it's holding GTP, triphosphate, it's in the on state. Think of it like a light that's supposed to automatically switch itself off a few seconds after you leave the room. Sure, it's normal for your cells to do one of these, to temporarily turn the lights on, do a quick cell division, then turn back off. But in pancreatic cancer, the light gets jammed. It's always on. The cell never stops getting that signal to grow. And what is uncontrolled cell growth and division? A punk-ass big cancer. This light gets jammed by a mishap in a single amino acid sequence, most commonly the G12D or G12V. In other words, the glycine that's at the 12th position of a normal KRAS protein accidentally becomes aspartic acid or valine. So the obvious question for the last 40 years is, can we just fix these mutations? Just turn the light off? It's obviously not that simple, and if it was, we wouldn't have nerds giving literal standing ovations at conferences if it was that easy. Because here's the nightmare of KRAS. Unlike most protein drug targets, it doesn't have nice deep pockets that a drug molecule can enter and bind to prevent its hyperactivity. KRAS is almost completely smooth on the outside. KRAS is so smooth that some scientists refer to it as a hot, greasy ball problem. Excuse me? Is anyone else kind of turned on right now? Oh, this guy is. Back in 2021, the pharma world got very excited as the FDA approved the first ever KRAS inhibitor. Known as sotorasib, researchers found a tiny hidden pocket near a very specific mutation called G12C. This same glycine, but now cystine's getting in the mix. A covalent bond between sotorasib and this new cysteine locked the drug in place to prevent KRAS from turning on. Textbook stuff. One little problem. This only works for G12C mutations, which make up less than 2% of all pancreatic cancers. The common mutations affecting everyone else, G12V, G12D, G13D, were completely untouched. It wasn't until recently when Revolution Medicines finally unlocked the secret to treating more pancreatic cancer mutations. But first, we need to see just how good their new drug worked in the clinic, and why it almost doubled patient survival. The trial was looking at a new small molecule drug known as Daraxonrasib. It was a randomized, open-label phase 3 clinical trial, which had 501 patients spread out across 59 clinical trial sites in North America, Europe, and Asia. An absolutely massive study. And Daraxonrasib had to be the second line of treatment. Their first line of treatment must have already stopped working. They were randomized into two groups, where one half received Daraxonrasib at 300 milligrams per dose. The other half received the investigator's choice of a second-line therapy. They absolutely blew away their primary endpoints. The median overall survival was 13.2 months. The median overall survival of other second-line treatments, that same 6.7 months. On average, Daraxonrasib allowed patients to live almost twice as long. But the other very important number to focus on isn't the raw months. It's something called the hazard ratio. Basically, the hazard ratio is the relative risk of dying compared to the other group. A ratio of 1 means that the two groups are dying at around the same rate. No difference. And based on other oncology trials, usually a good hazard ratio is around 0.7. But our newcomer had a hazard ratio of 0.4. That's a 60% lower risk of death at any given moment. I've read a lot of oncology trials recently, and this is exceptional. Now coming back to something that survival curves don't capture, but is incredibly important. Convenience. Remember that Daraxonrasib is a pill. You take it orally once a day. Very easy for patients. Most chemotherapies are given intravenously. They have to be provided by your healthcare provider. Many of them don't want to have to travel far to have an IV drip for a few hours just for it to make them not feel any better. Remember, chemotherapies have lots of side effects that just make patients feel terrible. Severe nausea, weakness, constant headaches, bowel problems. Together, these factors are enough for many patients to stop taking their treatment entirely, which inevitably means lower chance of survival. But a pill you can take with your breakfast, that's just routine. Just like your morning KRAS. Even the FDA clearly understood the magnitude of this trial, because they gave Daraxonrasib a whole slew of awards, which means it'll be approved significantly faster than the average drug that hits the FDA's desk. It also just got expanded access, meaning that some patients under certain guidelines can actually start using the treatment now before it's formally approved. And this almost never happens. This is only for cases where the FDA and other health regulators are very confident in the data that they're seeing. But by far, my favorite reaction comes from the ASCO meeting, or the American Society of Clinical Oncology meeting that happened at the end of May. People legit gave a standing ovation to a clinical trial readout. Multiple times too. This is said to have happened at least 3 times throughout the conference. I can't stress you how uncommon this is. You'd be pressed to find the tiniest of woos from a conference usually for like a Lifetime Achievement Award, let alone a standee. There is so much to be excited for about this treatment, and we haven't even gone to the chemistry part, which makes my nerd giblets tingle with the flames of 1,000 suns. So we established the problem. KRAS is super smooth, and other than that one example of G12C, there's not a whole lot for small molecules to bind to. So Revolution Medicines, the developer of this drug, asked a different question. Instead of looking for a binding pocket on KRAS, what if we invented one? So they made Daraxonrasib a tri-complex inhibitor. You can almost think of it like a molecular matchmaker. Imagine there's 2 people at a party giving each other eyes, standing kind of close, but they're both too nervous to approach the other. They give themselves every excuse to not interact. Daraxonrasib, EQ of a billion, grabs both of their hands and brings them together. And Daraxonrasib will not leave until they agree to go on another date. So these 2 protein pals are KRAS and a protein called cyclophilin A, or CypA for short. CypA is just an abundant, totally normal cellular protein that isn't usually anywhere near KRAS. They don't interact in pancreatic cells. It's only in the presence of Daraxonrasib that they form this tri-complex. And CypA specifically fits into certain binding sites in KRAS. Then KRAS can no longer bind to its downstream signaling partners. The growth signal stops, and the cancer cells also stop. Now the fun actually happens in this crystal structure. So come my chemistry nerds and sit, make sure you're hungry, because now we are going to satiate ourselves with some molecular binding simulations. Shown here is an X-ray crystal structure of Daraxonrasib bound to KRAS with CypA. The drug holds this 3-body complex together through 3 very specific interactions. The first interaction is mediated through this thiazole group in Daraxonrasib. This Y64 group, or tyrosine at the 64 position, gets exposed, where the phenol group of tyrosine is ready to hydrogen bond. Here's where water serves as a little molecular middleman, hydrogen bonding the phenol group with the electronegative nitrogen and sulfur atoms in that thiazole. And that's just the beginning. With the thiazole holding daraxonrasib in place, this indole core can pi stack with that same tyrosine. Pi. If you forget what pi stacking is from your early organic chemistry days, don't worry, I got you. Aromatic rings, these flat hexagonal ring structures that you see drawn all the time in medicinal chemistry, carry electrons in this cloud above the ring plane. When a separate aromatic ring sits on top of that, these electron clouds can interact. In this case, the stacking is between the pi bonds in that indole in daraxonrasib and the phenyl ring in tyrosine. Pi stacking is already pretty strong by itself, but combined with that hydrogen bonding, the interactions between KRAS and daraxonrasib are strong-leggable. One amino acid residue on KRAS interacting with two different parts of daraxonrasib. Very importantly, these interactions keep KRAS in the on state. They are not turning KRAS off. And then we add CypA back to the equation. While daraxonrasib is keeping KRAS busy in its on state, it can recruit CypA to that G13 binding pocket, thus blocking KRAS from binding to those downstream signals like GTP. And without a major energy source like GTP, these cancer cells no longer have the resources to continually divide. The fact that KRAS is stuck in the on state, that light switch does not turn off, is the magic of daraxonrasib. It's not dependent on the small molecule binding to that G12 site. In comparison, sotorasib, the previous best contender, could only work if it covalently bonded to the cysteine in that G12C mutation. The chemistry was too specific to the off state. That's how you go from covering just 2% of pancreatic cancer cases to almost 90%. Now, there's more and more papers coming out on this every single day, and the mechanism isn't fully ironed out. For example, back in March, this preprint suggests that daraxonrasib might actually be acting as a GAP mimic, and without getting too much into the details, it's this molecule that helps turn KRAS from its on state to its off state. This is either contradictory to or in combination to the mechanisms that we just described. Either way, it's fascinating to see just how many different ways KRAS can be targeted. Deciphering new mechanisms, new ways of binding to KRAS that were considered to be undruggable before will help researchers take that overall survival from 13 months to, hopefully, well over 13 years. All of this, of course, is very, very exciting, but we have clearly not cured all pancreatic cancer yet. 13 months is an amazing improvement, but it's still just 13 months. There are some cases that have a 5-year survival of over 90%. We'd like to see pancreatic cancer treatment get to that level. My main concern comes from the chemistry nerd part of me. We see that clearly daraxonrasib is great for many different mutations in KRAS, but KRAS isn't only found in pancreatic cancer cells. What does daraxonrasib look like in other parts of the body that are highly abundant in KRAS? For now, it's probably fine because this is in metastatic cancer. You probably want it to hit as many cells as possible that is high in KRAS, but eventually they will need to develop something that is more targeted. There's clearly still a lot of work to do, but this genuinely is an incredible step in the right direction. And I can only see pancreatic cancer treatment getting better from here on out. So now I'd like to hear from you. From what you've seen today, what are your thoughts on this whole situation? Is daraxonrasib really the truth? Is it the thing that's really going to change the scene for pancreatic cancers? Or is this just another pharma breakthrough that's getting more headlines than it deserves? Let me know in the comments down below because I read and respond to all of them. If you want to see what other big pharma innovations are happening to treat different types of cancers, I recommend clicking on this video here where we look at training your own immune cells can kill the cancer that your body started. Biomedical engineering is truly on one these days. But that's all from me today. Thank you all for stopping by and you stay classy, nerds.